today we have got two guest speakers. We have with us our first guest speaker, Dr. Amit Kumar from India, and he will be lecturing us on insurance awareness. And the second guest speaker is Professor Dr. Abdul Rahim Yaqub from Westwood, Kansas, USA. And he will lecture us on management of myelofibrosis in 2023. This webinar is brought to you by Mumbai Hematology Group, supported by Novartis and managed by Perfect Square. I thank Mr. Puru Gupta, Mr. Bhushan Kotwade, Mr. Rahul Deshpande and the team Novartis, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers for the day, Dr. Amit Kumar from India and Professor Dr. Abdul Rahim Yaqub from Westwood, Kansas, USA. All our discussants, who are themselves eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening. Tomorrow, that is Sunday, 6th of August 2023, from 11:30 a.m. onwards, we have a webinar on thrombophilia, when and how to investigate and treat, by Dr. Prantar Chakrabarti from Kolkata. Let me introduce our discussants for the day, here displayed in alphabetical order. To start with, we have Dr. Akanksha Garg from AIIMS Jodhpur, Dr. Bharat J. Parikh from HOC Vedanta Ahmedabad, Dr. Chirag Shah from Apollo Hospitals International Ahmedabad, Dr. Mallikarjun Kalashetty from Manipal Hospital Bengaluru, Dr. Prashanta Bhatt from KMC Hospital Bengaluru, Dr. Radhika KK from Nizam's Institute of Medical Sciences Hyderabad, Dr. Rajesh Krishna from Yennapoya Specialty Hospital Bengaluru, Dr. Rajni Priya Yedla from Mahatma Gandhi Cancer Hospital and Research Institute Visakhapatnam, and Dr. Rajkumar Ramaswamy from Vellamal Specialty Hospital, Madurai. Let me introduce our first speaker for the day, Dr. Amit Kumar from India. Dr. Amit Kumar is Deputy Vice President at Health Risk Management. He has about 22 years of experience in non-life insurance sector in India with varied exposure. Again, he has over 22 years of experience in non-life insurance sector in India with varied exposure, like 5 years of clinical experience with advanced neonatal resuscitation support certificate. He has about 9 years of overall experience in health insurance, different sectors, with 8 years of wellness experience at present. He is going to lecture us today on insurance awareness. Well, thank you so much. Over to you, Dr. Amit Kumar.
Thank you, Dr. Amit. A very good evening to our panel doctors and participants. First of all, I want to thank Mumbai Hematology Group for providing me the chance to speak on new advanced health treatment coverages under insurance. And once again, thank you, Dr. Amit, for such a lovely introduction. Here, just want to give you a quick background of Aon. That Aon basically is in business of helping people make better decisions. And Aon has more than almost 50,000 employees worldwide, which serves almost 120 different countries. And we directly place almost 180 billion health premium every year. So without further ado, I'm presenting my screen. Dr. Amit, just help me when you are able to see my screen, please.
Please go ahead.
I hope my screen is visible.
Absolutely. Crystal clear. Please go ahead.
Thank you, Doctor. So basically today we are going to discuss about the standardization guidelines by Insurance Regulatory and Development Authority of health insurance products in India. So basically, first I will try to give you some background about health, and then post I will take you through the insurance coverages part. So as a disclaimer, it's a complete awareness session. So we are not here to, promote any specific molecule or product. So just for your knowledge, uh, as you see, very recently we had seen that National Health Account released their reports in April for 2019-20, where we had seen that on my extreme right top, you will find that out-of-pocket expenditure of total health declines from 62.6% to 47.1%. Similarly, if you see in the on your extreme on the below graph in the same image, you will find that the government health expenditure that also increased from 29% to 41.4% in 2020. Similarly, if you see the government health expenditure share in country total GDP, that also increased from 1.13% to 1.35%. And when we talk about the share of social security expenditure of health, so which includes the government funded health insurance, medical reimbursement to government employees, social health insurance program in the total health expenditure increased from 5.7% to 9.3% in 2020. So these are some latest figure about health, which we got from National Health Account report, which is released by Ministry of Health and Family Welfare in April. So let's talk about the insurance part. As you also know that in India, in private health insurance, there are two types. One is your group health insurance and second is your individual or retail health insurance. So as the name indicates, group insurance obviously dominates the sector and 70% market share is there of group insurance. So basically, I will tell you about the group and individual insurance in detail in upcoming slides. So as you see here, so almost 274 million lives or 19% population would be covered, expected to be covered in by 24. So 8% life in group insurance you will find, and in individual health insurance you will find only 4% lives. So as I said, that group insurance already dominates this sector and 70% market is already covered by them. Similarly, what are the factors that driving the growth of private health insurance? As you know that rising awareness and affluence. So post-pandemic, uh, you had seen that a lot of people who struggled uh, in pandemic due to non-coverages or due to that they had not taken coverages in health insurance. So and now the awareness is there because of very high claim size. So now people are taking insurance cover as retail health policies also, and if they are working with some group, so they are covered under group health insurance. Similarly, lifestyle disease also are on rise. So previously what happens, you had seen that communicable disease are more in India, but now it's almost opposite. So like non-communicable disease also, hypertension, diabetes, cancer, you will see now India become the capital of all these non-communicable disease. Tax incentives, as you see that again in health insurance, incentive is also plays a big role, that people who generally take the retail health insurance, they can get the benefit of tax saving also. So people, that's also creating awareness among people. Proactive IRDA, so insurance regulatory and development authority also showing proactiveness by covering modern treatments and advancement in technologies. They are covering new molecules, new therapies, new robotic and AI based surgeries. So that's why uh, we can say now that IRDA is also proactively working in this particular field. Competition, yes, again, competition also a big factor. In India, there are almost 27 to 30 private health insurance companies are there in market, through which you can take retail and group health insurance as per your need. Similarly, products also create completely different dynamics here. So in pandemic, we had seen that insurance companies came up with new coverages like COVID care products. Similarly, in diabetes care also, you will find diabetic care policies, cancer care policies, where in OPD coverages are also there, where you can take the consultations, your investigation charges upfront through the OPD policies. Similarly, digital intervention to improve customer experience also is there because of services, online claim submissions. So digitization is again a big thing. So because of digitization now, people can buy policies online, they can pay the premium, they can file the claim, they can check their claims status online. And similarly, when we talk about the sales channel, so very easily on these insurance company website, you can go and pay your premiums easily, and you buy these products online. Awareness programs, lot many corporates are now doing awareness programs for these specific products, about the claim processes, about the insurance. So these are some factors which I told you that are really helping us in driving growth in private health insurance in India. Moving forward, as I initially shown, that there are two uh, uh, specific products in market in private health insurance, that is retail product and your group owned. So what is the difference in self owned and group owned? So in retail health insurance, you have to pay premium from your pocket, and every year you have to pay on the same date, otherwise there would be a gap in premium. Similarly, in group owned, where you are working, like if, for example, if you are working with a company, so that particular company purchase a tailor-made policy from the insurance, and they cover you and your family as a group owned person. So just give you some background about the IRDA also. So IRDA, as I said, that IRDA is your Insurance Regulatory and Development Authority. IRDA comes under Finance Ministry, and the composition of this authority is a 10-member team, which consists of chairman, 5 full-time members, 4 part-time members, basically. And in India, IRDA is whole sole, you can say, regulator or authority who generally take care of TPAs, insurance companies, insurance brokers, agents. So to just check the services and other things, IRDA generally come into picture. So if any insurance company come to market with new product, they have to take approval from IRDA before launching that particular product in market. Similarly, they do time to time audit of all these third party administrator, TPAs, insurance brokers. They check the licenses of agents also. So it's a regulatory authority above the all these 4 specific service providers. Standardization of guidelines by IRDA, it's a very important slide, and uh, previously I discussed with Dr. Parekh also, and most probably that will answer his question. So in 2016, the first standardization happens by IRDA, and at that time, not many changes have done in the insurance policy guidelines. And post that, in uh, July 2020, again the similar standardization of guidelines happened, which came into force in October 2020. So in that particular standardization of guidelines, what happens, they had divided the master circular into three sections: the guidelines of standardization of health insurance, second, the standardization of exclusions in health insurance, which is very important, like previously, for example, infertility treatment, psychological treatment, all these treatments are not covered. ARMD, age-related macular degeneration treatments. So these, I had given you some examples that these particular things are not covered previously in policy, but now post standardization of guidelines, now all these exclusions become inclusion in the insurance coverages. And the third section is your standard individual health insurance product, where they had made some changes in room rent, RMO, and other services. So to check the entire document, you can scan this QR code. Here I will take a 5-second or 10-second pause. So you just scan this QR code, you will get the complete details of standardization of guidelines. And post this session, you can go through the entire document because it's a lengthy document. It will take some time to read. So here I'm taking 5 to 10-second pause. You just scan this QR. So it will give you a very nice information. Hope everybody scanned this. So moving to my next slide. Again, it's a very important slide. So as I told you that post standardization of guidelines in October 2020, in modern treatment and advancement of technologies, insurance company covered these 13 specific treatments, which is in front of your screen, and which is directly related are oral chemotherapies, immunotherapies, if you see, then stem cell therapies. So these are some specific treatments, uh, I think, which you cover in myelofibrosis also. And this is my duty to give you the complete information on this. So these are some specific treatment post standardization of guidelines which are now covered. And to give you more information on this, I think there is a specific standardized product in market that is there already with all the insurance companies. So that specific product name is Arogya Sanjeevani. So this particular products you will found with HDFC, Bajaj, Apollo, Niva, Bupa, Oriental, National, New India, whatever insurers are there in market. So if you check the Arogya Sanjeevani policy, you will find the very good coverage of modern treatment, because IRDA has given instructions to all insurance companies post this October 2020 that they have to cover all these treatment. But what insurer has done smartly here to cut down the claim cost, they had put the sublimits on all these treatments basically. But the Arogya Sanjeevani is the only specific policy, or you can say product, which covers the modern treatment up to 50% of the sum insured. So in all Arogya Sanjeevani policies, you will find 5 lakh rupees sum insured, where if you take any treatment for all these above mentioned 13 ailments, so you will get 2.5 lakh rupees coverage. So that is a big catch. So that's why I had put some watchouts also in this slide. So when you purchase any product from market, always see what is the hospitalization coverage, what they cover, is daycare cover in that particular policy product or not. So what is the sum insured, what are sublimits in oral chemotherapies and other products, because on these 13 specific procedures, they had put sublimits also. So they are not paying the entire sum insured amount. So, be careful on this part. So when you purchase any product from insurance product from market, always check the sublimits, because similarly waiting period is also there in watch out. So these two things you have to check, that what are the waiting periods. Like in retail health insurance, when you check the policy document, you will find, for example, cataract. So first 2 years cataract is not covered, Gallbladder surgery is not covered, hernia surgery is not covered, hysterectomy is not covered, or up to post 4 years, you are able to take a claim for total knee replacement. So all these are some, waiting periods, which I'm telling you for your knowledge. So which everyone have to check when they are purchasing any insurance product from the market. Similarly, pre-existing disease also, and the sublimits also, that what all sublimits they have put on these specific 13 disease. Moving forward, now comes to claim process. As you all know that there are two type of claim processes. One is your cashless and second is your reimbursement. So in cashless, basically if you are a insurance policy holder, then in that case you don't have to pay upfront any amount to that particular hospital if that particular hospital is under the panel of that specific TPA, because all insurance company settle their claim through third party administrators, and it is third party administrator responsibility to check and settle all the claim documents uh, for which you had put the claim basically. So on TPA, you will found if you check the third-party administrator site, you will found a complete hospital list on their website, where you can check and you can filter out through your city that that specific particular hospital is covered in their panel or not. And if you are going to that particular hospital which is already covered into their panel, so you will get cashless facility. So in cashless, what happens basically? So when you reach to hospital, there is a TPA desk, which they will give you a pre-authorization form. And in that pre-authorization form, there would be two columns. One is your personal detail and second is your medical details. So personal details, basically you have to fill with your name, age, gender, and your policy number and other details of your policy. Second part would be filled by your treating doctor, where he has to mention the symptom details, the diagnosis, the procedure, the costing, approximate costing, and post that with that pre-authorization form. Generally, hospital put other documents also with that, like investigations, your consultation papers, and they fax all those documents to third-party administrator. So third-party administrator again have a team of doctors who generally check your policy coverage, your other coverage details, and accordingly they release the initial amount. And when you first time send these documents, they release if treating doctor is asking, for example, 50,000 rupees. So initially they approve 15,000 or 20,000 rupees. But at the time of final submission of claim, you will get the complete amount with the deductions also, because in insurance sector there are certain things which are not payable, and there is a list from IRDA which is approved list, and according to that list some of the things are not covered, so they deduct those things which you have to pay from your pocket, and rest of the claim would be paid by insurance company. Similarly, in reimbursement claim, first you have to take the treatment, and post that you have to collect all your document from the hospital, in which you have to collect discharge summary, investigation reports, your bill receipts, your detailed breakup bill also, and you have to fill the claim form, and you have to submit all those documents to third party administrator TPA, who generally take 15 to 20 days time to settle the claim. If there is any query, again they will send you the query that these are the documents which they require further to settle your claim. And initially when you fill all those documents, so they will settle your claim. In cashless claim also, many times you had seen that it take almost 6 to 7 hours to give the final authorization. So what happens, I just want to take another 4 minutes or 5 minutes here to give you a clear picture, because many times we had seen that at hospital TPA desk, not many people discussing about this thing, that my claim is not settled. It's almost to 4 hours, 5 hours. Hospital has shared all the documents, and still I had not received any payment from the third party administrator or insurance company. So what happens generally, you also know that hospital uh, take their own time, basically because in hospital also, first resident doctors have to prepare discharge summary. Post that, nursing department take clearance from all the parties, like they check the investigation report section, they check the pharmacy section, they check the uh, finance section also, and post that they send the entire docket to hospital TPA desk. So that entire process itself take 2 to 3 hours at hospital end. And post that, when they fax these documents to third party administrators, so at TPA also, they take again 2 to 3 hours to access that claim. They check all the policy documents again. They check the what are the deductibles in the complete bill provided by hospital. If there is any shortage of document, again they write back to hospital that these many documents are short, kindly send all those documents to us back again. So just want to try to tell you here that this entire process itself take 5 to 8 hours generally. That's why, you know that you will see lot of hue and cry at the time of final settlement of the claim. Moving forward, I had already covered all this, so I'm just, in sake of time, I'm just moving these slides. So again, this is important slide, the document claim document checklist. So as I told you earlier, that there is two procedure, one is cashless and second is reimbursement. So for filing reimbursement claim, this particular checklist is very important. And if these documents are not there in your file or in your docket, the TP is not going to settle your claim. They are again sending back you a query letter that these documents are short. So always, take care of signed claim form, all prescriptions in original, doctor consultation, payments, receipts, sign and seal, all original medicine bills with sign and seal, investigation reports, and other details. So many times, some people say that I need all these original documents for my further treatment. So in that case, what happens? You have to write a letter to third party administrator TPS, and you have to mention that you are taking further treatment and you need the original investigation report and discharge summary for further treatment. So they return your investigation report and discharge summary. Your bills and other financial receipts are not going to be give you back, because that for audit perspective, generally uh, they put all those things with themselves. Moving forward, so healthcare practitioner role, as I said, again, in insurance, healthcare practitioner role is the biggest. So at the time of diagnosis, the complete details, they have to put the clinical protocols, what they had followed, the duration of the disease. If there is any history of any particular disease, they have to put, they have to share all the consultation papers. And similarly, for the insurance counselor also, you will find that counseling is also very important. And now these days, you will see in many hospital insurance TPA desks, you will find the insurance counselors who will guide you about the your policy coverage, your sum insured, what you will get or what you will not get. Moving forward, again, it's a very important slide for everybody. Steps to handle rejections. So lot many times you had seen that lot many cases rejected in spite of you provide them the complete details. So in corporate insurance, there is high probability of reimbursement, because group health insurance generally covers all the ailments from day one. When I say the day one, so you will get all the treatment coverage from day one in group policies. But in retail health, basically, as I told you initially also, that in retail health there would be waiting periods. Like I had given you example of cataract, gallbladder, and all that. So in retail health insurance, many times you had seen that lot many claims have been rejected. So how you are going to handle those? So initially there is a, grievance addressal forum at the insurer site. So if uh, you think that your claim is not settled properly, you can file uh, 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 your application at grievance addressal forum, and again in 15 days time they will revert you back with the complete details that why they had rejected your claim and they are not paying that. So in spite of that, if you are not satisfied with their reply, again there is a ombudsman, like you had seen similarly the ombudsman in banks also. So similarly in insurance also you will find the ombudsman office where you can file your claim, and both the ombudsman office generally send the notice to both the parties, the insurer and the insured, and they check. In spite of that also, if you are not satisfied with the ombudsman reply, the final resort will be the litigation. So you have to file a claim in consumer court where you will get the settlement of your claim. So now these days, what we are seeing that not many uh, companies are there now which help you in settling down your claim, and one of those are Insurance Samadhan, Claims Buddy. So all these are now some of the solutions which where you can take help from them, because generally uh, uh, they will take all your claim documents. They will ask the entire docket of claim documents from you, and then they will again check all the documents serially, and they will check the policy coverages also, and accordingly they make a reply on behalf of you and submit to insurance company. And through that they are trying to help all the people who have faced the rejections for in their policies, and they take a very minimal you can say percentage of your claim, like 4% or 5% of your claim as a fee to settle down your claims on behalf of you. So these are the some important points which I want to share with you. Thank you so much for your time, and thank you everyone who to give me this opportunity to provide you this information. Now I hand over again to Dr. Amit, for further insights.
Thank you, Dr. Amit Kumar, for that wonderful insight on the insurance awareness. It was a new subject for us, but you really made it really beautiful, fantastic, and really awareness for us regarding the claim past, cashless facility, and all sorts of what's going on in the hospital. Thank you so much for being with us. And we will do our question answer sessions at the end. So in the meanwhile, I think we have a time. So if any discussants want to ask any question to Dr. Amit Kumar, then please go ahead, because you have got 10 minutes time.
Sure.
Use your hand raise signs.
Thank you, Dr. Amit Kumar.
Yeah.
Wonderful. I got satisfaction and reply to my all questions. Right. Well, we
Yes,
have
sir.
to get educated and educate our patients as well, and have proper documentation and steps to expedite the claims and to
Right,
reduce
sir.
the rejections. Right. Good.
Thank you,
I
sir.
have a question, Dr. Amit Kumar, sir, regarding this stem cell transplants. Does almost all the insurance company do cover these stem cell transplants?
Yes, yes. Post this October 2020 standardization of guidelines, so now IRD has given them a clear, you can say, a notice that they have to cover the stem cell transplantation also. But as I told you that smartly, all these insurance companies had put the sublimits. So when we talk about the sublimits, so for example, I had given you example of the Arogya Sanjeevani policy. So in Arogya Sanjeevani policy, there is a sum insured of 5 lakh rupees. So up to 5 lakh rupees, you can take the treatment. But what they had done, when you go for a stem cell transplant, so you will get cover only for 2.5 lakhs, as they had put a sublimit to that particular ailment or treatment, basically. So that is a catch. So that's why I always said, always check the policy wordings, always check the policy product which you had purchased from market. So generally in group health insurance, you will never see such type of fights. But in retail health, obviously you are going to see this.
So suppose if the cost of transplant is, say, for example, 12 lakhs, and the policy is of, say, 3 lakhs. So maximum 3 lakhs the patient will be able to get.
Yes, yes,
Rest he has to pay from his pocket.
right, sir.
Another question is basically we have got Chief Minister Fund, Prime Minister Fund, and then patient also has got insurance claim also along with that. So can all the three be merged together?
Yes, what happens, first you have the bigger portion, if, for example, I have two insurance policies from different insurers, for example. In first policy, I have a sum insured of 5 lakhs. In second policy, I have a sum insured of 3 lakhs, correct? So the bigger amount I'm going to cover from the 5 lakh sum insured policy, where I have to submit all my original documents. So post submitting those documents, that particular insurer is going to give me in writing that they had settled my claim up to this particular amount because my sum insured is 5 lakhs. So they are covering that much part only. So similarly, I will go to the second insurance company with that particular letter and I tell them that this is a duplicate set of documents with this particular letter from that insurer that they had already covered that much amount. Rest of the amount you have to cover in that policy. So it works like that, sir.
One more question I have. Sometimes, the insurance, what the patients have taken the insurance about, and the whole family is covering that insurance. So one is not about one patient, actually, one member of the family, but it's about 5 to 6 members of the same family.
Yeah.
How that insurance cover is, say, for example, of 5 lakhs for the entire family. How is it the insurance company going to divide the cost?
So basically, that is a family floater policy, which you said. So that particular amount floats to everybody.
Okay.
That's why we call it family floater. So if you had taken a family floater policy, in that case, you will get a sum insured of 5 lakh rupees, for example. So if, for example, I had taken a claim of 2 lakh rupees, then that 3 lakh rupees claim you can take for daughter, son, parents, or anybody, because that particular amount is there only. So it's not like that you had taken a family floater policy and you will get 5 lakhs each. So it's not like that. So be clear in that, because if a family floater policy is there, that particular amount is going to float on each and every one.
Another thing, with some questions are coming up regarding, suppose the patient has got, for example, aplastic anemia, newly diagnosed aplastic anemia. Tomorrow, the patient says that I have just booked my insurance claim. Insurance, I just filed my insurance yesterday only. So how long it will take for that claim to be passed now? Today is a newly diagnosed case of aplastic anemia. Yesterday only he has taken a new insurance policy.
So in that case, he has to check, sir, because many policies from day one, they don't cover. As I told you that every policy is having a waiting period. So similarly, all the retail policies have a waiting period of 30 days, where first 30 days, beside accident claim, you are not able to claim anything. So only accident is the specific treatment which is covered if any claim arises post purchase of policy within first 30 days. So within first 30 days, nothing is going to be covered.
Perfect. Another one thing, what our patients have a difficulty is that when the claim has been put, actually what they are returned back is, or the company says that this is a genetic disease. And if something is there in the cytogenetics also, that's what we do. Cytogenetics we do for every patient. And for example, it says there's some, for example, deletion 5q or monosomy 7 is there. And the moment they see all these reports, then the company says that this is a genetic disorder. We cannot give claim. Is it true?
Yeah, it is true in some cases, because now lot many products in market which cover genetic disease also, sir. So IRDA had already passed a circular for this. So in not many products, not many retail health insurance, you will find that they cover the genetic disorder also. So that's why I said in beginning that awareness is very important. Everyone has to go through the first 2 pages of the policy where you will get the coverages, where you get the exclusions, where you get the waiting periods, where you will get the sublimits of the policy. So first 2-3 pages is very important when you are going to buy any product. Even don't uh, go what agents also said. Always check the policy document thoroughly before purchasing any document.
So if the doctor mentions it very clearly that this is not a genetic disorder, then the claim can be passed after that?
Yes. Because frankly speaking, treating doctor, whatever treating doctor will write on his letterhead, every insurance company have to, uh, take care of that particular thing, because TPA doctors having, you can say unlimited knowledge, because treating doctor is obviously a super specialist doctor who is treating the patient. So obviously, TPA doctor is not going to, you know, confirm that thing. So if super specialist is confirming that particular disease is not a genetic disease, and the etiology is that for that particular ailment, so it is going to be paid by insurance company.
Thank you so much. Thank you, Dr. Amit Kumar, for being with us. It was a wonderful talk and a wonderful discussion. Thank you for solving all our queries. And we have some
Thank
more
you.
queries coming up after the lecture of myelofibrosis. Our next
Sure,
guest
sir.
is waiting for us. Please be with us, tune with us to the last part of the lecture.
Sure,
Let me
sir.
begin again. Well, our second guest speaker for the day is Professor Dr. Abdul Rahim Yaqub from Westwood, Kansas, USA. Professor Dr. Abdul Rahim Yaqub is professor at the Division of Hematological Malignancies and Cellular Therapeutics at University of Kansas Medical Center, the University of Kansas Health System, Westwood, Kansas, USA. Dr. Abdul Rahim Yaqub is a professor of medicine at the University of Kansas Medical Center, the University of Kansas Health System, with a clinical focus on hematological malignancies and cellular therapeutics. He received his medical degree from Jordan University in Amman, Jordan. He did his internship at University of St. Louis, followed by residency in internal medicine at St. Louis University, followed by fellowship in hematology oncology at University of Arkansas for Medical Sciences, Little Rock, Arkansas. His clinical interests include hematological malignancies, especially myeloproliferative neoplasms, MDS, and other leukemias, with research emphasis on the pathogenesis and treatment of these neoplasms through clinical trials. He is an active member in several cancer-related organizations, including the American Society of Hematology, American Society of Oncology, Southwest Oncology Group, and the Myeloproliferative Diseases Research Consortium. He is going to lecture us today on management of myelofibrosis in 2023. Well, over to you, sir, for your lecture.
Well, thank you very much for the kind invitation. I'm gonna share my slides. It really is a pleasure and an honor to be invited to this venue to speak to your audience and your colleagues. Let me share. I am assuming you guys can hear me okay, and you can see me okay, and you can see my slides.
Absolutely,
Right.
yes. Please go, sir.
Perfect. So, and I hope, again, please interrupt me at any time if you have a question about any of the slides. So I'm very happy to have this more of an open discussion than didactic. But we're going to cover a broad spectrum today about myelofibrosis. We're going to talk about the pathogenesis, diagnosis and prognosis, and then management, and then the future and what the future is going to bring to our patients. So we're going to cover the whole spectrum of the disease, hopefully over the next few minutes, less than an hour. So as you're all aware, we try to classify cancers according to cancer families and pedigrees so that we can cluster them, give them the right terminology, and treat them as groups and specialize in these diseases. Myelofibrosis is is one of the classic MPNs, myeloproliferative neoplasms. It is one of the 3 classic syndromes of MPNs. When we use the word myelofibrosis, it really includes the primary myelofibrosis as well as myelofibrosis secondary to transformation from other MPNs, such as polycythemia vera and ET. Roughly 60% of myelofibrosis is primary and 40% is secondary myelofibrosis, which means a transformation from PV or ET to myelofibrosis. Once we call it myelofibrosis, we treat it the same, regardless whether it was primary or secondary. All these patients are clustered together and treated the same way. Myelofibrosis is a rare cancer. It is an orphan disease. The global incidence is less than 1 per 100,000 person years. In the US, it's somewhere between 0.5 to 3 per 100,000 person years. Really rare disease. Compare this to Hodgkin's. Hodgkin's is 30,000 in the US. So really a rare cancer. And globally, it's there's about 100 to 150,000 new diagnoses every year. So it is a rare cancer, but for patients who live with it and require unique attributes or unique management, so they're a little bit different from the other cancers and they require special expertise. This is usually a cancer of late middle age. It really isn't necessarily like MDS and AML, where this is a cancer of elderly. A lot of those patients are actually fit, and you will have to really explore all the therapeutic options up front to maybe even offer them curative therapy. Historically, the median survival was very poor for those patients, really comparable to gastric cancer even. When you put things together, it's one of the higher risk cancers with a very poor survival. Things are very different now. Most patients do much better than what the historic records report. So a very unique feature of MPNs and myelofibrosis is that JAK-STAT signaling is the driver in all patients. It's one of those unique cancers where you really know exactly why the cancers happen. So to simplify this, our blood production, all hematopoiesis, is absolutely strictly controlled by cytokines, receptors, and intracellular signaling. This is a very meticulous process, very well controlled, and it goes through cytokines binding receptors and receptors signaling through the JAK family, causing JAK-STAT activation. STAT is a transcription factor, and it results in production of blood elements. That's the normal hematopoiesis. Now, abnormal hematopoiesis is when you have cancer, is when there's a dysregulation in this pathway. Now, dysregulation can be because of many things. The most common and the most famous is JAK2 mutation, which is a gain of function in JAK2 kinase, which is right here in the intracellular part of the receptors, which results in constitutional JAK-STAT activation and constitutional transcription, and everything that is related to myelofibrosis is because of that. All the excessive blood production, all the symptoms, the splenomegaly, the fibrosis, it's all purely related or directly related to JAK-STAT activation. Now, there are other ways to activate JAK-STAT pathway. So the other form is MPL mutation, which is basically a mutation in the transmembrane protein, but it results in the same intracellular pathway. And then the third, most recently discovered, is calreticulin, in which a mutated protein from the endoplasmic retinaculum is bound to the receptor covalently and causes constitutional activation. So whichever is the driver mutation, the intracellular effect is the same, and that intracellular effect is what causes cancer. And that's why we treat myelofibrosis the same, regardless of which driver mutation they have. And a JAK-STAT inhibitor is always going to be the backbone of any therapy for myelofibrosis because it's the driver pathway for this cancer. So the main features of myelofibrosis is that patients have abnormal blood counts. They have fibrosis in the bone marrow. they have extramedullary hematopoiesis, which causes enlarged spleen and other organs. Patients have extremely heavy burden of symptoms universally, and this is a progressive cancer. It always gets worse with time. So these are the hallmarks of myelofibrosis. And these I want to discuss in the next few slides to just kind of give you more understanding of the clinical burden of this cancer. So fibrosis is basically the position of fibrous tissue in the bone marrow space abnormally in the setting of cancer. Now, fibrosis of the bone marrow can happen in any cancer. So finding fibrosis in the bone marrow is not diagnostic of primary myelofibrosis, but it's necessary to make that diagnosis. And the deposition of fibrous tissue is made by non-malignant fibrocytes that are affected because of the excessive blood production. So basically, it's the complication of all the cytokine storm that happens in the bone marrow environment. Now, there are many causes for fibrosis in the bone marrow that is not primary myelofibrosis. So if you find fibrosis of the bone marrow, you really have to make sure you know the cause. There are benign causes and malignant causes, and any cancer in the world can cause this. But we have to be, that is not the same as making a diagnosis of primary myelofibrosis. But it's necessary to prove either MF2 or MF3 to make a diagnosis of myelofibrosis. Now, extramedullary hematopoiesis, which in all patients means enlarged spleen. Splenomegaly is present in 90% of patients at presentation and 100% of patients eventually. Basically, the reason why splenomegaly happens is because the neoplastic cells migrate through the blood and seed in the spleen, and they reconstitute extramedullary hematopoiesis in the spleen. So in one way or another, it's basically metastasis of the bone marrow cancer into other organs. In patients who undergo splenomegaly, splenectomy, then the cells will seed in the next organ downstream, which is liver, and then lung, and then lymph nodes. So basically, it really follows the path of similar to metastasis in solid tumors. An enlarged spleen is symptomatic. Patients find it uncomfortable. It causes compression on the other organs, but also an enlarged spleen causes portal hypertension and variceal bleeding and liver damage, actually. And sometimes patients have liver fibrosis because of splenomegaly. A big spleen can result in cytopenias because of hypersplenism. And a big spleen also is one of the more common reasons for bone marrow transplant failure because of graft failure. So having an enlarged spleen is a major problem for patients. And that's why when we talk about treatments, we talk about spleen volume reduction. It's very meaningful to actually reduce the spleen in these patients. Now let's talk about symptoms. So again, all patients with myelofibrosis are symptomatic. It's really very hard to imagine a patient with myelofibrosis who's not symptomatic. It just depends on how well you take a good history from them. Symptoms are, very broad, not always specific, but it's universal. In addition to having high symptoms, many patients report that their quality of life is also impacted because of their symptoms. So it's not necessarily I have fevers, but they're also actually having poor quality of life because they can't sleep because of the night sweats. So it really is also functionally a problem to those patients. And then this is a very nice illustration, is that those symptoms of myelofibrosis are very generic, not really a lot, very specific in MF compared to any of us feeling sick or having a bad week or having other illness. The only difference is the severity. So the light gray curve is basically, if you run the symptom questionnaire on healthy people, yeah, some of them are fatigued, some of them have numbness or other symptoms. But if you run the same symptom score on patients with myelofibrosis, you get the dark gray curve. Basically, it's the same distribution, just a lot more intense symptoms. And the difference also is that fatigue with myelofibrosis does not get relieved by sleep or rest. You're always tired, you wake up tired, and there's nothing that can help with that without medical therapy. Now, there are the B symptoms, which are night sweats, fever, and weight loss. These are unique, these are specific, and they are actually prognostic. So when we talk about prognosis, having these three symptoms is associated with poor prognosis, and they're part of our prognostic systems. There are many tools to evaluate symptom burden. So the MPN-SAF is a standard of care. It's in the NCCN guidelines. This is something we use in every study, and it's something we issue in every patient, and it's available in all languages from this website, spotlightonmpn.com, which is really, and this is now a public access. So I hope you guys use that in your patients. It's available in all languages. The next hallmark of myelofibrosis is the progressive nature of myelofibrosis. Patients who live with myelofibrosis without treatment will continue to have worsening blood counts, worsening symptoms, worsening spleen, and eventually they will transform into either MDS or AML or bone marrow failure. And patients with myelofibrosis will likely live a shorter life and die from their disease without therapy. So it is progressive. And that means that even if you have successful therapy early on, patients might progress. That's why we always need more therapies, because patients will always progress. Even when they're successful in their therapy, you always need to have more options after they progress. So to make a diagnosis, WHO criteria got updated last year, 2022, but the myelofibrosis criteria did not change, actually. So they're the same as 2008 now, which is there's major criteria. You have to meet all three and at least one minor criteria, which are pretty standard now. It's just the morphologic features, having erythrocolonality, and excluding other diseases, as well as at least one minor criteria. So these all remain the same since 2008. Now let's talk about prognosis, because patients with myelofibrosis can be very variable, and we need a tool to tell which patients are going to do better than others and which patients are going to do worse, and which therapy to give to which patients. So the goal for prognosis is listed on this slide. We want to give patients the right expectations. We want to counsel them about their outcomes, but we also need to risk stratify, find out who have the highest risk disease and who gets the higher benefit, higher risk therapies, and allow for more personalized and individualized access. But also, it's very important to triage patients who should get an early transplant and who can wait, and also to uniformly be able to design clinical trials. So the original prognostic score is the IPSS. This was designed for patients with primary myelofibrosis at diagnosis. It was very simple, clinical features only. You get all these 5 features: age, symptoms, the B symptoms only, and anemia, leukocytosis, and blasts. And based on that, you create 4 categories. The lower 2 are called lower risk MF. The higher 2 are higher risk MF. Usually the 5-year survival is the cut point. If patients who have under 5 years are called higher risk disease. So this was a very good tool to risk assess patients at diagnosis for primary myelofibrosis. This is not applicable to secondary myelofibrosis. This is only a diagnosis. It's not dynamic. There's many limitations to this prognostic score. And that's why additional prognostic scores were developed. And for the sake of time, I've listed this on the slide. But really, the standard treatment that we use on a day-to-day basis is the DEPS Plus. It includes all the 5 clinical features from IPSS, but also include different attributions, also include the cytogenetics, the severity of the cytopenias, no molecular results yet. And basically, these scores are able to give you a good discrimination strength to be able to tell who's going to do well, who don't need therapy, and who are going to do poor and they need early therapy with transplant. That's really the big advantage of having those scores. Now, I would like to bring to your attention that all these scores, all 3 of them, were published before 2011. That was before Jakafi. That was before NGS testing for everybody. We didn't even have calreticulin mutation, MPL mutation discovered by then. So these are scores that were designed way before the modern era of myelofibrosis. So you have to take them with a grain of salt. Patients do much better now, and we have a lot better tools now. But we still use these scores to clinically assess patients and design trials, although they're really, really old and missing a lot of the modern era diagnostics and therapeutics. Now, in addition to predicting survival, they also predict transformation risk to AML. So that's also a good tool because patients who are high risk are actually going to do poorly either by dying early or transforming early to acute leukemia. Now, the more modern era now, and if you guys remember, calreticulin was discovered in 2013 and 2014 for MPL. So these are more recent discoveries. So once we discover that patients who are calreticulin positive, and these are all mutually exclusive, do twice as good as patients who are JAK2 mutated. So having a calreticulin mutation is a good thing. It's a more favorable risk. Patients live twice as long as the same patients who have JAK2. And patients who don't have any driver mutation, they live half as short or half the life of a JAK2 mutated. So yeah, the driver mutation itself matters a lot. So patients with CALR will have the best life expectancy compared to JAK2 MPL, and patients who don't have any mutations will do very poorly. So now we've learned that the driver mutation matters. And then we've also learned that there are high-risk mutations listed here. And those high-risk mutations are also associated with much worse prognosis, especially if you have more than one. So now we know a lot more than what we knew with the clinical scores, which brings us to the more modern prognostic scores. So if you have access to sequencing, and I overheard you guys discuss that in the previous talk, if you have access to molecular testing, that would be actually the most accurate way to give a patient prognosis through the MIPS 70 plus version 2, which is really the most powerful tool we have. And that tool will give you 5 different categories with very accurate life expectancies. And again, the higher risk is when 5 years or less is expected. That's when you know these are the patients who really high risk disease. And then there's also intermediate and 2 categories of lower risk disease. So this is the standard of care if you have access to molecular data for your patient. And then the MySickPM is a tool that people use for secondary MF, and I find it very of little help in general, but it is something that we occasionally go to. Now let's talk about treatment. So when we get patients with myelofibrosis, as you understand, they're going to have variable outcomes. So we really have to pivot your decision making to what the patients actually need. So we want to shrink the spleen, yes, that is important. You want to improve the symptoms. You want to improve the survival. Now, every patient might have different priorities. So you might make different decisions based on your patient's symptoms or decisions. But also, this is a progressive cancer, and patients will have different decisions and priorities as they live longer with their cancer. So this is a dynamic process. You will make different decisions for the same patient over time because their cancer will change. So the general approach to this is that whichever is prognostic scores we use, you think of patients as either lower risk or higher risk. Patients with lower risk, you can observe them, do symptomatic management, maybe pick the higher risk of the lower risk and just watch them more closely. Patients with higher risk disease by the prognostic scores, we think of them more seriously. We refer them early to transplant. They all get a JAK inhibitor, and they might get both transplant and a JAK inhibitor. And then we also try to manage their low counts and their symptoms and so forth. So that's the general approach to these patients. That's what the NCCN guidelines also say. So patients with higher risk, they get a JAK inhibitor. The place under 50, pacritinib is the only approved drug. If you're over 50, it's ROX, fedratinib, or pacritinib. And then all of them get transplant evaluation. So everybody gets the JAK inhibitor, transplant evaluation. If they're transplant eligible, they go for transplant. If they're not, they stay on JAK inhibitor for life. That's generally the approach to this. Unfortunately, all the guidelines are just one page. That's it. There's really not a lot of options after that. Again, if you fail therapy, you just switch to a different drug. There is not really, it's just one page of guidelines for those patients. There's not a lot of tools in our toolbox. Now, referral to transplant is very important. And we know for a fact that patients with a higher risk disease, they would benefit from early transplant, even within a year of diagnosis. But patients with lower risk disease, it really is advisable to find an HLA donor, but maybe not jump onto transplant until the relatively higher risk disease. So having this knowledge might guide you at the timing of the transplant. But again, being a progressive disease, most patients will progress and they will need a transplant eventually. Now let's talk about the JAK inhibitors that we have. So the first drug that was approved is ruxolitinib. It was approved based on 2 phase 3 global clinical trials, the COMFORT-1 and COMFORT-2. Those were presented and published in 2012 in New England Journal of Medicine. Both were positive. So in both studies, patients with intermediate 2 or high-risk myelofibrosis were either treated with Rux or a control arm. Again, intermediate 2 or higher, and platelet counts of 100,000 or higher. That was the inclusion criteria back then. And the dose was selected was 15 or 20 milligrams for these patients. That's very important. So these 2 studies were both positive, and ruxolitinib was approved in the US in 2011. It has different, the brand name is Jakafi in the US, and it has different brand names elsewhere in the world. But basically, what Jakafi does is for spleen volume reduction, the primary endpoint was achieved by 42% at the 6-month mark, but 60% at any time. Patients who responded benefited from therapy, but the median time to progression was 3.2 years. So eventually everybody progresses, and the median is about 3 years. And that the dose of 10 milligrams twice a day is the least effective dose. Anything less than that is not going to work. Now, this was very impactful because patients who respond have excellent quality of life, they thrive, they gain weight, the spleen shrinks, they live longer. Shrinking the spleen is associated with survival. The more you shrink it, the longer your patients live. So this is actually very impactful. And that was appropriately led to the FDA approval, and this still is our best drug so far for myelofibrosis. Symptom improvement, that was secondary endpoint, was achieved in about half the patients, which is fantastic. Half the patients had a deep response. Most patients had some response. And then survival. Survival is the only drug with survival data. So here's the survival. So I want to remind you that this was a randomized study that allowed crossover, and almost all patients crossed over at 9 months, the median 9 months. So the survival was superior in the treatment arm compared to the control arm by over 1.5 years. So basically, even though patients crossed over at 9 months, they still lived shorter than patients who got ruxolitinib at the beginning. So that's why it's important that when patients have a diagnosis of MF, that they get therapy early on. And then the other important information is that the intermediate 2 by IPSS usually has a life expectancy of under 4 years. On the study, it was 8.5 years. So you almost doubled the overall survival for your patients with this therapy. So that's when I told you that the old IPSS are obsolete, or not obsolete, just outdated, because they were before Jakafi. Now, after Jakafi, you can even double the survival data. So patients do much better now than what they did back when the IPSS was designed. This is the dose response. So if you look at the left, the bigger the dose, the better the response. This is linear. Patients who are getting less than 10 twice a day were not better than placebo. So it's actually in the package insert. If your patients cannot tolerate 10 milligrams twice a day for 6 months, you should look for other options. That's actually in the Jakafi package insert, which is true. You should not really keep patients on cosmetic small doses of Jakafi. You should really push for dose escalation. Now, here's what happened after Jakafi. So Jakafi was approved 2011. Before approval, the green line on the right is the actuarial overall survival. Most patients on average lived less than 2 years with myelofibrosis before Jakafi. Since Jakafi, we are at the blue line. Patients who got got Jakafi after approval, all patients from the SEER data, they're doing so much better. We've changed the natural course of the disease now that we have therapy that actually improves their outcomes. Now, the other drug that is approved is called fedratinib. Fedratinib was approved based on a phase 3 study called Jakarta. The primary endpoint was spleen reduction. The control arm was placebo. It was a very positive study. It's a very active drug. And it works in patients with platelet counts 50 or higher. So it's a very active drug. And then fedratinib was also studied in second line after Rux failure, and it also was active. So patients after Rux in Jakarta 2 still had about 25 to 32% response rates, even after Rux failure. So it's an active drug for spleen volume and for symptom improvement. Now, the problem with fedratinib is that during development, there was a clinical hold for 6 to 7 years because of cases of Wernicke encephalopathy. There were 9 cases of Wernicke encephalopathy reported in the patients treated on the Jakarta study, mostly with a dose of 500 milligrams daily, which we don't use anymore. So that resulted in a clinical hold. So everybody on the study was taken off study. So we lost follow-up. So we really did not have any, we will never have survival data because all patients were removed of study. But then that was investigated, and there was really truly only one confirmed case of Wernicke's and one likely case. So basically 2 cases of Wernicke's reported on the study. Since then, there were 2 other cases after marketing. So basically 4 cases in the history of MF were Wernicke's. So that was the biggest issue with the drug development. Now this drug is approved since 2009, 2019, and we're using it, but there's a box warning with Wernicke's encephalopathy. So we always check thiamine. We give patients thiamine. We try to control their GI side effects so that they don't throw up, and so forth. Now, it's an active drug, but it still has side effects, significant GI side effects. So you have to be preemptively managing the nausea and vomiting and diarrhea. And also it causes cytopenias significantly. So you have to support patients through that. Now, the third JAK inhibitor that is approved is pacritinib. Pacritinib is a little bit more unique. It is JAK1 sparing. So by not blocking JAK1, it's only a JAK2 inhibitor. It does not cause as much cytopenias. But also you can think of it as a little bit weaker drug because it only inhibits JAK2, not JAK1. It does affect other targets. And famously, the IRAK1 inhibition is now a big thing in cancer. IRAK1 and IRAK4 is a big target goal in cancer treatments because blocking that affects the toll-like receptors and all the NF-kappa pathway and all the cytokines. It can actually result in significant improvement in patients. So that is a unique attribute of pacritinib. So pacritinib was studied in a unique subset of patients that we call them the cytopenic MF. So you're probably going to hear a lot about the phenotypes of MF. There's a proliferative MF and there's a cytopenic MF. Cytopenic MFs are patients with myelofibrosis and have low platelets, low hemoglobin, low white cell count. They usually have higher risk disease, and they're usually not good candidates for ruxolitinib or fedratinib because both drugs are approved in patients with platelets over 50,000. But for patients with severe thrombocytopenia, the only drug that is approved is pacritinib. So these are the unique patients where pacritinib was studied. There's two studies. The PERSIST-2 was the pivotal study. And based on the PERSIST-2, the dose of 200 milligrams twice a day was the superior arm. It was superior to the best available therapy, and patients were allowed to actually get RUX as the therapy. So even when RUX was the control arm, pacritinib was the superior therapy in patients with severe thrombocytopenia. So basically, to repeat this, for patients with platelet counts under 50,000, that's defined as severe thrombocytopenia, pacritinib is the only drug that was studied and the only drug that is approved at the dose of 200 milligrams twice a day. It causes better spleen responses and better symptom improvement for these patients. And then even when RUX was the control arm in the same subset of patients, pacritinib was still the superior therapy. And then after that, there was another post-marketing study to supplement the diagnosis. It's a PK with high emphasis on PK, different dose schedule, with 200 milligrams twice a day being one option, and that was actually the superior therapy. So there is dose-dependent benefit. 200 milligrams twice a day is the optimum dose. If you use that, 30% of your patients will respond, both by spleen and by symptoms. So this is a summary slide for the approved agents, the dosing schedule, and some of the common side effects for your review. Pacritinib and fedratinib are both flat doses. Ruxolitinib is dosed according to the platelet count, both pacritinib, Rux and fedratinib cause cytopenias, but pacritinib does not cause cytopenias. So it's a drug of choice for patients with low blood counts. So these are the approved drugs. Again, these are very good drugs. Patients respond to them, but eventually everybody will progress. So what do we have after that? So the next part of my study is about all the investigational agents and agents in development. So how do I approach this? Again, we still have patients who we have to treat, and there's still, again, we have success stories and we have stories where we're not so successful. So here's what I do. And somebody who gets ROX, for example, first-line JAK inhibitor, and they're absolutely refractory or intolerant, I would just use another JAK inhibitor, just switch them to another drug. And that would be a simple decision, basically. For patients who are receiving first-line therapy and they're having suboptimal response, maybe their spleen is still enlarged, maybe they're still symptomatic, I always try to improve the dose escalate as much as possible. And then also look for a clinical trial with combinations. There's studies with add-on therapy. So they continue in their same therapy and you add something else to it. So that's my approach to those patients. Now, for patients who have had a JAK inhibitor and benefited from a JAK inhibitor and then continued on it and then progressed after JAK inhibitor failure, it's unreasonable to expect that it's wise to give them another JAK inhibitor. I think you need to look for a different class altogether. So these patients need something different, not even JAK inhibitor based. Look for trials that have unique novel agents. So that's my approach to these patients. So to put that in a diagram, so this is your first-line therapy. Everybody gets a transplant evaluation. Everybody gets a JAK inhibitor or both. And then once patients progress, you look for other options. For suboptimal responders, you look for an add-on therapy. Now, this has been successful, so people are now doing combo upfront. And then when that fails, you look for non-JAK inhibitor class drugs. And there's many of them in development. So these are examples of the add-on therapy. So we had so many studies, so many drugs being designed in that way. This is a very busy field. A lot of those studies are ongoing. We don't have a champion yet. A lot of those studies are actually not being successful. But again, this is still an unmet need. We still look for that because not everybody who gets ROX or other JAK inhibitors get the ideal response. A lot of them are suboptimal responders, and they could benefit from an add-on therapy. One example was the PI3K inhibitor. in which, say, just an example, ruxolitinib blocks JAK-STAT, but there's another escape pathway, which is PI3K. If you inhibit that, you boost Rux. That was the example. So basically, you max out Rux, then you add a booster to it, which is this parsaclisib drug. That study at phase 2 was very active. The phase 3 studies failed because of design and activity issues. So unfortunately, that's not in development anymore. The other agents in development also not meeting their goals. Navitoclax, if you will hear about this soon, but in same design, same concept, different target, BCL-XL. But phase 2 study was great. Phase 3 studies are not really being very successful. And then the third drug that is possibly can be positive is pelabresib, is a BET inhibitor, it's an epigenetic modifier that's also in phase 3 studies. If the study is positive, it might become a new standard of care as an add-on therapy. So a lot of those drugs are now in development, and hopefully we are looking for a signal of improving the field forward with combinations. So because those were successful as add-on, a lot of those drugs are being studied now upfront. So now you get a new patient with myelofibrosis, and studies are randomizing them to either get Rux or a combo with Rux. That's really now the new paradigm. And again, there's so many of those studies going on right now. A lot of them have promising results, but no final results yet. But hopefully in the future, we will have a combo. So more patients would respond, they would respond faster, and they will respond in a deeper way, and the responses will last longer. That's the whole premise of combinations. Now, after JAK inhibitor failure, so the category of patients who benefited from JAK inhibitor, then they failed, those patients do very poorly. They have a very poor life expectancy, close to 1 year, and there's really no approved drugs for these patients. This is a big unmet need in myelofibrosis. There are drugs being studied in this. So the one drug that might get FDA approved this year still is called momelotinib. So momelotinib is a JAK inhibitor, but it really is unique in which it's a very strong activin inhibitor. Basically, it blocks hepcidin and induces improvement of hemoglobin better than, basically reverses anemia in these patients. So it was studied in this phase 3 study specifically for patients with anemia and symptoms. This was not necessarily for the spleen. This is a unique study because those patients failed JAK inhibitors, they're very anemic, and momelotinib was studied to improve symptoms and anemia, and the study was positive. The study is a positive phase 3 study. This drug is under FDA review for approval. If it gets approved, it's likely going to be second line, and it's going to be ideal for patients with anemia. Although momelotinib has very strong data even in first line setting in other studies. So here's the data on the study. Momelotinib was superior to the control arm. The control arm was not placebo, it was danazol, which is an active drug. So it was superior to the control arm, the danazol in anemia, and that was sustained. And this is public domain knowledge. It's been presented and it's accepted as positive. So let's talk about the non-JAK inhibitors. There are many drugs in development. Many of them are undergoing extensive research. This is a diagram of the targets. There's so many targets that we're all investigating extensively. I highlighted 3 that are gonna, discuss that are probably more promising. Navtemadlin is an MDM2 inhibitor. It's now in phase 3 studies. It's a very promising drug, and it's undergoing a very rationally designed phase 3 study. Hopefully that will be positive, but we're really looking forward to this drug. And then I'm going to talk about 2 novel agents that are very unique, that are potentially disease modifying. So tagraxofusp, or SL401, is a conjugate protein. So in one end, it's IL-3 that binds to IL-3 receptor, which is CD123. And on the other end, it's covalently bound to diphtheria toxin. If you've heard of diphtheria before as kids, we still get vaccines for it, so that's why we don't get diphtheria, but the toxin is very poisonous, very powerful. So when the tigraxofus binds the receptor, it goes inside the cell, the diphtheria toxin is released. It's a strong proteasome inhibitor, results in cell death. This drug is approved in a rare leukemia called blastic dendritic cell tumor, BPDCN. So it's already FDA approved for that. And it's been studied in myelofibrosis, and it's very active, and now it's going into multiple combinations. It's unique because it actually hits a very unique target. So it was studied in very relapsed refractory patients who have failed all therapies, failed transplants, failed chemo. And despite all of that, there's high response rates in these patients who have failed everything else. And the response rates were both spleen responses and symptom responses. And in these patients, the survival improved to 26 months. If you remember, those patients who live about a year, they lived over 2 years with therapy. So we think this is a disease-modifying therapy and very successful with very little side effects. And now I have this investigator-initiated study combining tigraxofus to pacritinib. Hopefully, this combination of two drugs that were studied in high-risk patients can be very successful in patients with myelofibrosis with higher risk features. Another drug is imetelstat, which is the first-in-class telomerase inhibitor. This drug was studied in MDS. This year, they presented an ASCO phase 3 study data that was positive. It might actually get FDA approved for MDS. It's very effective in MDS and anemia. It's also being studied in myelofibrosis. The unique clinical trial is meant for overall survival advantage. So this is a very unique study in which the goal is overall survival. And then the newest innovation, things we're very excited about, is calreticulin antibodies. So basically, calreticulin is a protein that lives only in the endoplasmic retinaculum. Calreticulin mutation is a driver mutation. It's actually the second most common one after JAK2 mutation. So it's present about 1/3 of MF and 1/3 of ET patients. The mutation is very specific in a location in the calreticulin that makes it more water soluble. So it leaves the retinaculum and it binds the receptor in the cell. And when the receptor goes to the surface, it dimerizes, and this results in constitutional JAK-STAT activation by binding to the receptor from the outside. This is very unique and very interesting because this calreticulin does not exist in us. We don't have calreticulin expressed in our cells. It's always stuck inside the cell. When you have an antigen expressed on the outside that shouldn't be, it makes it a target for antibodies and immune therapy. So that's really why this is so unique, and it's a niche. It's a targetable goal for myelofibrosis. So basically, if you design an antibody that hits that, it would only be cancer specific, only in patients with that mutation, and it's likely not to have any other side effects because it only hits one target. So this drug that was recently presented in ASH as a plenary session, the Insight 989, is an anti-calreticulin antibody that binds to that unique antigen, prevents dimerization. And when that happens, cells can't proliferate. They shut down the signaling completely. And it's unique. It only works in calreticulin mutated clones. It does not work in JAK2 mutated clones or in normal cells. It has no toxicities or side effects or activity in other patients. It's only specifically active in CALR mutated, and it's dose dependent. So that's now in a phase 1 study to try to find the right dose, and hopefully this will be one of the more exciting targetable mutation. Now we are treating myelofibrosis in a mutation-specific pathway. This is very exciting to us because that was our dream, is to be able to do individualized therapy, treat every mutation specifically. So that was my last slide. Thank you very much for your attention. It's a very exciting field. I hope we covered appropriately how to make a diagnosis, how to approach a patient, how to prognosticate, and how to treat them, and give you a teaser about the future. Hopefully the future is bright for these patients. I'm happy to take any questions.
Thank you, sir, for that wonderful lecture. I will give a break of 5 minutes because the previous speaker audience questions were left, and I will just ask some questions from the audience which were left from the previous speaker. So in the meanwhile, I request all the discussants to please put the raise hand signs. So in the meanwhile, we'll start within 5 minutes with Dr. Yaqub.
Excellent.
So 5 minutes, is it okay for you?
Oh, absolutely, yes. Yeah.
Thank you, sir. Dr. Amit, some questions were left.
Sure, sir.
I just received it. The first question is from Dr. Archana Shanware. Can patients who have received cancer treatment get insurance policy?
Yeah. So lot many products are there specifically for cancer treatment that called is, critical care policies. So in that critical care, the coverages are for almost 36 specific ailments, which is critical and chronic in nature, and cancer is one of them. So where you will get a lump sum amount for the treatment, and parallelly you can take the retail health insurance, normal health insurance coverage, where you can cover the cancer treatment basically.
Thank you, sir. Another question is from Dr. Suman Chakraborty. Is there any coverage post-hospitalization? And if yes, what's the period?
Come again, Dr. Amit?
Is there any coverage of insurance claim post-hospitalization? And if yes, what's the period after which a person can
Yes. So in every health insurance product, there is a pre-hospitalization and post-hospitalization coverage. And those coverage is specific and they vary product to product basically. So in some of the products, you will find that pre-hospitalization, pre-30 days are covered, and post-hospitalization, 60 days treatments are covered. But similarly, you will find 60-90 days also, 90-120 days also. So it depends totally on the product, which product you had purchased from market. So according to that product coverage, you will get the pre-post hospitalization cover.
Thank you, sir. Dr. Suman Chakraborty wants to know something more about critical care insurance policy. If you can please elaborate the same.
Yeah, so lot many insurance companies now, providing critical care cover also, and in your normal health insurance policy as a rider also they provide this coverage. But if you had purchased specifically a critical illness plan from market, so that's also there where you get a lump sum amount. For example, if you had taken a policy of 10 lakh rupees, so there is a waiting period of first 90 days, 30 to 90 days, which cover your survival period also. Survival period, when we talk about that, when patient diagnosed with cancer and the survival of that particular or prognosis is not that bad that patient will die in between that survival period from 30 to 90 days, then it will be covered. They will provide you a lump sum amount at the start of the diagnosis and in the mid of the policy also. So lot many details are there, uh, even on IRDA site, where you can check the different critical illness products also. So as I said that every insurer have different coverages. Similarly, in critical illness policies also you will find different coverage as per product which are available in market. But certainly that will give you a good coverage, a good amount also. because that specifically cover the critical illness only.
Thank you. And then the last question from Dr. Archana Shanware. If a patient has cataract surgery in both eyes, why are the approved claim amount different? And why is the claim same for different categories of e-card insurance?
Dr. Archana means to say that they got two different amount for cataract surgery.
Cataract surgery in both the eyes. Why is the approved claim amount different for both the eyes? And second question is, why is the claim amount same for different categories of e-card insurance?
So in that case, I need to check what exactly the coverages are there, because in some policies there are fixed packages for cataract surgeries. Like in PSU policies, you will find that 32,000 or 30,000 or 38,000 is a fixed amount which you will get for each eye. So it totally depends on product to product what all products are there, what product that particular person has purchased for coverage of cataract surgery, because in some products there is no specific guideline. So whatever treatment you will choose, according to that treatment, that particular coverage you will get. So like in one eye you had gone for MICS, so you will get the MICS package. And similarly, if in as you know, and another eye you go for laser surgery, and obviously that amount will be around 1 lakh to 1.5 lakh, so you will get a different amount as a coverage. So it totally depends on the insurance product, what type of coverages are there in that particular product.
Well, sir, thank you, Dr. Amit Kumar, for that wonderful lecture as well as wonderful discussion. It really helped to get aware about this many insurance claims and the policies. Thank you so much for being with us.
Thank you.
Now I request all the discussants to please put your raised signs so that we can start our question answer sessions with Dr. Jacob. And in the meanwhile, I have some questions from the audience till all the hand and size get figured it out. So first question is from Dr. Hitha B. Patient with calprotectin positive myelofibrosis, grade 3 myelofibrosis, osteomyelosclerosis, mesosplenomegaly, no cytopenia, normal cytogenetics, blast of 6% in the smear, high intermediate risk, can't afford stem cell transplant. What treatment will you offer?
Yeah, so thank you. So what you described is somebody who is really high risk by many features. And a JAK inhibitor, again, is a standard treatment for these patients. Now, the 6% blast is something that's concerning because patients who have 6% blast, and this is a progressive disease, and patients with 6% blast have a trajectory towards getting to 7 and 8 and 9 and 10 and so forth. And once patients get to 10, their prognosis is as bad as acute leukemia. So again, the standard of care for these patients is to offer them a JAK inhibitor, but also if the patient hasn't had a bone marrow biopsy recently, repeat their biopsy and NGS. Sometimes there's more blast than you think in the bone marrow, and they already might have acute leukemia by now. And also you might find targetable mutations. So some of the targetable mutations we did not talk about is IDH. So a lot of the patients with myelofibrosis progress through IDH1 and IDH2 mutations. And in those patients who are not going to get a bone marrow transplant, there are IDH inhibitors that can be of help, even with combination of a JAK inhibitor. So things to look for, again, that's the minority of patients, 20%. But when you find a mutation like that, that'll be very good for the patient. You will really do a lot of good for them. So it depends on your access to trials for your patients, either a JAK inhibitor or a calreticulin antibody on a study, if that's available to you. Also biopsy and sequencing, and if you find targetable mutations, also access to trials with targeted therapy, that will be very helpful to this patient. Yeah.
Thank you, sir. Dr. Mallikarjun Kalashetty, your question, please.
Thank you. Thank Dr. Amit. Thank you for a very lucid presentation. So I think there is increasing data to suggest earlier usage of JAK inhibitor both for better tolerance and efficacy in myelofibrosis. Our challenges have been Hep B reactivation, tuberculosis reactivation, and Zoster reactivation. So we have had the vaccine becoming available just now. What are your recommendations to prevent infective complications? And we know that it is effective both in JAK positive and JAK negative MFs. But in your clinical practice, in real world practice, have you found any difference with regards to efficacy and tolerance? Thank you, doctor.
Okay, yeah, very good question. That's actually a very important topic. There's multiple aspects to your question. So let's start from the easier part. Yeah, so JAK1, JAK2 mutation, when the comfort studies were done, we did not have CALR MPL, right? That was before we even discovered them. So there was analysis done, and patients who were JAK2 positive or JAK2 negative, they all responded equally the same. You can't tell the difference. So really, everybody responded equally well. So it's neutral to your driver mutation. The responses are the same, the side effects are the same. Now, the side effects. So inhibiting JAK1, as you mentioned, is immune suppressive. That's why there's a JAK1 inhibitor for rheumatoid arthritis, right? They use the same class of drugs as immune suppressive in autoimmune diseases. And patients on ruxolitinib have more infections, they have more cancer than other patients. But you're also giving them ruxolitinib because they also have a cancer that is going to shorten their lives. So it's a risk and benefit analysis. Now, during the COVID era, we've learned that patients on Jakafi are actually doing very poorly. They do as bad as the CLL patients on anti-CD20. So it is definitely, we've learned that the hard way, that JAK inhibitors and anti-CD20 are the two worst drugs to fight COVID in terms of risk for patients having bad outcomes. So from all these things, we've learned that there's definitely a risk to this therapy. There was also data about second primary cancers and lymphomas and all of that, really not in any way practice changing, but there's definitely a signal, you can't ignore it. So what I do for those patients is that before I start Jakafi, I talk to patients about at least the vaccination. So if you want to vaccinate patients, vaccinate before you do Jakafi. Once you do Jakafi, they don't respond to vaccines as well. So especially shingles, because the risk of shingles on JAK inhibitor therapy is very high. It's almost the same as a bone marrow transplant. And if patients get shingles once, keep them on vaccinations all the time. Now, outside of that, you really manage those patients like all your other cancer patients on active therapy, and the risk of infections is something we all deal with all the time with all the drugs we use and with chemotherapy. So we just manage them the same as other patients. But again, you have to educate them about the risk of infections, and you really want to invest in vaccinations before you start therapy. Because once you start therapy, they don't respond to vaccines as well.
Thank you. So would you consider valacyclovir or cepram prophylaxis in them if some of them are on steroids?
Secondary prophylaxis, yes, I actually do. But again, not in if somebody never had shingles, I wouldn't. But if they had shingles once, I keep them on prophylaxis for life, yes. It's about 10% per year, that's the rate, right? So 90% will be fine, but 10% will get it, then yeah, you prophylax them for going forward, yeah.
Thank you. Thank you. Thank you.
Thank you, Dr. Mallikarjun. Dr. Akanksha, your question, please.
Yeah, hello, sir. Thank you for the wonderful talk. So, I wanted to ask you regarding the duration of ruxolitinib that you give to your patients, especially the intermediate and the high-risk patients before taking them up for transplant, and whether you're giving any post-transplant maintenance to these patients.
Okay, so it depends on if you're a transplanter or not. So again, there's real life time limits to transplant. Like if somebody goes to a transplanter today, they're not going to get a transplant tomorrow. They get a transplant at best in 4 to 6 months. So there's that real life limitations of transplant will not happen anytime soon. But there's actually a lot of data from Seattle that patients who have received at least 6 months of Jakafi do so much better than patients who don't get Jakafi. And based on the Cutler data with the analysis, the ideal time to transplant is the first year, not necessarily the first 6 months. And you have a window. So I prefer that patients get the maximum benefit from Jakafi before transplant, which is at least 6 months. On the Seattle data, that added 10% survival to their cohorts from baseline, from whatever the historic data, 10% extra benefit by having enough exposure to Jakafi, which I think is at least 6 months before transplant. Now, after transplant, none of those drugs are approved for maintenance. And ideally, honestly, if you're doing a transplant and you cure your patient, there is no target to hit with Jakafi. But Jakafi is approved for GVHD. Any after allo for any disease, not for MF only. So as the previous question was, the risk of infections, risk of cytopenias, it is not a riskless treatment. So we don't do it routinely for maintenance, but we do it for GVHD on the rocks for the right patients only. Yeah.
Thank you, Dr. Akansha. Dr. Radhika, your question, please.
Thank you, sir. Thank you for the comprehensive talk. My question is, in a high-risk primary myelofibrosis who is planned for bone marrow transplant, do you recommend initiating the patient on Jakafi at least 6 months prior to transplant to reduce the disease burden, more importantly, the symptom burden, and then take up for transplant?
Absolutely,
Jakafi
yes.
for 6 months prior to.
Yes, absolutely. Just like the previous question, transplant will not happen now anyway, right? There's always going to be this delay until you do all the system, screenings, find a donor, and all of that. So you're looking at a few months anyway. In patients on Jakafi, they have lower spleens, they have less symptoms, they gain weight, they become better candidates for transplant when they respond. So it will improve. It's like pre-rehab, basically. You improve their performance status, you improve their stamina, their strength. So they become even better candidates for transplant. That's one thing. The other thing, the spleen, the bigger the spleen, the more likely graft failure, right? So when you shrink the spleen, you actually improve the chances of the graft not failing. So that's important. Our transplanters hate a big spleen, right? So if I don't shrink it with Jakafi, they're going to do radiation, but they want the smallest possible spleen before the transplant. And that's why you're hitting multiple birds with one rock this way. Is you shrink the spleen, you improve the rehab, you buy time, patients are feeling better, and at the end of the day, based on the Seattle data, they actually live longer. They actually do better. They get a better outcome after transplant.
I used the same concept for one of the patients who had a HLA matched sibling. 3 months on Jakafi, he developed miliary tuberculosis.
What was that?
What's same thing.
Infection? Yeah.
Miliary tuberculosis, COX.
Tuberculosis. Okay. Yeah.
3 months of was planned for a transplant. He had a HLA matched 10/10 sibling. So 3 months on Jakafi, he developed miliary tuberculosis. I have initiated him on ATT. So how many months of ATT can I take him up for a transplant? Should I complete the whole course of ATT or post-intensive?
But you could argue that if you took him to transplant early and he had TB, he would die immediately, right? Same thing, right? Because the immunosuppression with the conditioning regimen is even worse. If anything, you might have saved the patient's life by not transplanting him. In Jakafi brought up his TB to you. Now you can treat the TB. But if you went to transplant and you myeloablated him, then he had TB, he would die immediately. So if anything, these months of Jakafi would bring up all the, the caveats and the weaknesses in your patient. So this might not be a bad thing in that sense. I'm not a transplanter, but if you get an invasive infection when the patient is completely myeloablative, there's no recovery from that. But if you catch it before the transplant, at least now you know about it, and the patient probably had TB before, right? He just became miliary. But at least you stop Jakafi, it's reversible. But the transplant is not reversible. Yeah, the chemo is not reversible.
Patient had a marked thrombocytopenia. 10,000 is the platelet count. So I have added on L-Trombopac to support the thrombocytopenia.
Was that before Jakafi or after Jakafi?
Even before Jack, his count was somewhere fluctuating 60, 70 and all, 60,000, 70,000. But once he had an attack of pox, his platelets dropped to 10,000.
Yeah, so in general, this is an absolute contraindication for Jakafi to treat patients under 50,000. So usually your reflex should be to stop Jakafi when it's under 50,000. Now, thrombocytopenia is 100% reversible from Jakafi. Now, if your patient did not recover his platelets, it's probably because of the infection or the cancer or something else happening, but it's not the Jakafi. But you should, yeah, I'm glad you stopped Jakafi because it's contraindicated when platelet cancer under 50,000. Yeah. There's serious risk of bleeding on that. Yeah.
Yeah, actually, my transplant, the whole plan of transplant got postponed here. I have a second question, sir. The NGS is becoming increasingly accessible for routine clinical use in hematology now. We are using NGS like rampantly in a PMS years or wherever. Do we need to repeat NGS at regular intervals as some high-risk genomics may pop up over time in primary myelofibrosis?
Very good question. So, yeah, myelofibrosis is a chronic cancer, right? It's not fast and very few surprises. Like you can tell when your patient is doing well or not doing well clinically. Then you do a bone marrow biopsy to prove that. So I wouldn't do routine surveillance bone marrows and NGS on anybody. But usually when patients progress clinically, you have to do a bone marrow, and that's when you repeat their NGS. And usually you will find a new mutation, yes. Usually when patients progress, there is usually a new event, whether it's a new abnormal karyotype, new mutation. Usually something will be extra different when you repeat the bone marrow biopsy. Usually when patients progress from MF to accelerated phase, it's either a TB53 mutation or a RAS mutation or IDH mutation. So usually the progression events are known. So and also if you repeat the bone marrow and you find one of those three, you'll be able to predict this patient will do poorly. So I would do the bone marrows when you have a clinical suspicion that your patient is progressing, and that's based on a clinical data, but not just routinely for surveillance.
Yes, sir. That was helpful. Thank you, sir.
Now, sometimes I use interferon a lot in patients with lower risk, prefibrotic MF. And those patients, in some patients who respond, they do very well. And you can see their driver mutation burden going down with time. You can do that on the blood. You don't need to do a bone marrow on that. But that's the only situation where I do routine follow-up for the driver mutation is with the interferon, because you can see it go down with time, which is very nice. Yeah.
Thank you, sir.
No, good question. Thank you.
Thank you, Dr. Radhika. Dr. Bharat, please be ready with your question. I will take two or three questions from the audience. Dr. Hita wants to know that in case of JAK2 negative myelofibrosis, what targeted therapy will be useful? Yeah, so JAK2 negative MF could be CALR or MPL, right? So we now have a CALR target. We don't have MPL target. So that's the only thing that we know of. Now, the only other targets that have agents are IDH. So if you have IDH1 or IDH2 mutation, those are targetable. So these are in terms of like unique specific agents. And the word targeted therapy has become very vague these days because Jakafi itself is targeted therapy and it is not mutation specific. So it will work in JAK2 negative as well as JAK2 positives. So is fedratinib, so is pacritinib. So they're all targeted therapy, but they're not only for JAK2 mutation, they're for any MF patient.
Now, outside of that, so that's why for your JAK2 negative patient, all these are still the same standard of care. And in the future, there will be a JAK2B716F specific drug. There's actually a drug that's going to come for that. So that will be unique for the JAK2 mutation patients. Now we have a drug only for CALR patients. Maybe we'll have a drug for MPL patients. So maybe in 5 years, we will actually have a different drug for each mutation. We don't have that yet, but we have all JAK inhibitors that work in all patients. We have the non-targetable commercial targetable mutations, and then we have the drugs we talked about today, right? Like tagraxofusp for CD123 positive patients, which are all myelofibrosis patients are. You have telomerase inhibitors. These are targetable agents. All the drugs we talked about today are targeted agents, but not specifically that you screen patients for or not. You should not exclude patients from this therapy yet. So again, the definition of targeted therapy has become very broad these days. But I hope that helps answer your question.
Yes, sir. Thank you so much. Another question from Dr. Rajkumar Ramaswamy. What is the definition of JAK2 inhibitor resistance? Is it the spleen size or the platelet count important, or the combination of both along with the symptoms?
Thank you very much for this question. There has been so many work done on this because, again, we know when things go great, right? If somebody has great spleen reduction, symptoms are gone, gaining weight, that's wonderful, right? But that only happens in 40% of patients. 60% of them will be suboptimum, right? Is this resistance or suboptimum? That's one definition. And then there's a few, 5%, or absolutely primary refractory. They progress on therapy. So those exist. Now, based on also the resistance and tolerance is also defined by what else can you do about it. If you have nothing else, when we had only Jakafi, I don't care if patients have suboptimal response, they're still going to stay on Jakafi, right? Only if they have a little bit of benefit, they'll stay in Jakafi because they don't have anything else to do. But now that we have options, we're getting more liberal at saying, you know what, this is suboptimum, this is resistant, this is intolerant, let's do something different. We have more options. So among the acceptable definitions is that patients who cannot tolerate 10 milligrams twice a day of Jakafi, that is failure of therapy. Patients who have progression, right? These are definitely acceptable, obvious black and white. These are failure of therapy. Now, for patients who don't achieve at least 50%, at least 30% reduction in spleen by exam, patients say this is suboptimum. Patients who don't have at least 30% reduction of symptoms, again, that's suboptimum. Patients who respond then progress, that's black and white. So there's some things that are black and white. It's obvious, no-brainer, somebody progressing and not responding and all that. These are black and white. And then there's the options that are gray zone. These are all based on what you're going to do about it. If you have a better therapy, yeah, you look for suboptimums because maybe the better therapy is combination, right? Yeah, you look for these patients. But if you're going to switch therapy, you really have to have failure, not suboptimal response. And that should be black and white progression, not iffy. Maybe patients are not doing so well. Maybe the spleen is not shrinking fast enough. You really want hardcore, absolute progression on these patients.
Thank you so much. Dr. Yaqub, Dr. Bharat Parekh, your question, please.
Yeah, Dr. Yaqub, wonderful talk. We enjoyed.
Thank you.
Now, if you are having a young high-risk patient posted for transplant, and you know that some family members are having related diseases, then from the rest of the family, during the screening of donors, will you include the sequencing as NGS to rule out apparently healthy people harboring the deleterious mutations?
That is a great question. We will have an answer for it in 10 years. But it's a great question. So again, in AML, in the diseases are more acute, the DDX41 and all these germline mutations that we're finding in our patients are becoming very visible, and there are now very clearly defined syndromes that if you have this, skip the whole family. Now, MPNs do cluster in families. We do not know, we don't actually have a germline mutation that is known to cause MPNs, but there's certain polymorphisms that don't have commercial testing yet, that there are families with predilection for MPNs. But we're not yet at the era where we're not selecting a donor based on a known mutation. In a full match sibling is such a great option for a transplant that we should really have a really high bar to refuse them. But you have to do your due diligence. At least do a CBC and do an exam and make sure the patient does not have a disease. But say if the patient does not have a disease, if your donor, let's say, does not have a disease, maybe you actually do a JAK2 mutation on them. We know that the natural history of acquiring a mutation to having a life-threatening myelofibrosis is measured in decades. For patients who have myelofibrosis now, who are severe, they have had their cancer for 20 years minimum. We know that for a fact. So even if your donor is healthy now and you're harvesting him and you're wrong and he actually had a low level of unknown disease, and that's still in the big scheme, you're giving your patient a graft that is good for a few decades anyway. So I think it's very important that we start looking at that, especially in patients with known germline cancer syndromes that predilect for myeloid diseases, and not just MPNs, actually all myeloid diseases. But if you get a donor with a normal CBC, normal exam, no obvious morphologic disease, it's very unlikely that you're doing harm to your patient by donating from the sibling. It's probably better than donating an unrelated donor with GVHD and mortality and all that. Yeah. And it's definitely better than untreated myelofibrosis, because your patient will do very poorly with that. A young patient will do very poorly with that.
Thank you.
Thank you,
And there
Dr.
was a lot of work to find germline drivers, by the way. It's not because we didn't study it, but there is not one that is clearly found. So it was studied extensively. There is not actually a known mutation after extensive testing. There's no known familial germline mutation predicting for MF. So it was not because of lack of looking. A lot of people looked and there isn't one. So it's more polymorphisms and clustering, not more than that.
Thank you.
Thank you, Dr. Bharat Parikh. Another question from the audience, Dr. Sanjukta Rao wants to know about the role of interferon in myelofibrosis. Do you use it frequently?
So there's a lot of exciting stuff about this. So in patients with low-risk MF, pre-fibrotic, I think it's a standard. It's really a standard treatment. I use it. A lot of people have. There's enough literature, and now there's a prospective study. There's a prospective study with ROPEC interferon alpha 2b in patients with low-risk MF or pre-fibrotic MF going on globally. You guys can actually even open it at your sites. It's by Pharma Essentia from Taiwan. So they're doing a dedicated study for that. So that's exciting, actually, that we're looking at that. And there was recently the presentation of the Ruxo-Pig data, which is ruxolitinib combination with pig interferon, with Pegasus. And the results are amazing, honestly. It's almost, the best combination we have so far. So if that ever goes to a phase 3 study, that'd be great. But I don't use that yet in standard of care. This is too new, and it's really very selected patients on that study. It's the French data. It took them 10 years to complete. So obviously they were very, very picky on their patients. But there's enough signal that there might be an activity there. And if you guys are interested, you probably should activate that Pharma Essential study for ROPEC interferon alpha 2b.
Thank you, sir. Another question from Dr. Hita B. She wants to know that do you routinely use erythropoietin for treating anemia and myelofibrosis?
Yeah, we probably honestly, you don't really have a lot of options. Every drug we have causes anemia. The cancer causes anemia. The drugs cause anemia, and anemia is the biggest challenge on daily management of these patients. So whatever works for anemia. So here's what works. EPO works in patients with low EPO. Danazol works in many patients. Thalidomide and prednisone work, actually. There's good data for that. Luspatercept is in clinical trials. There's actually good data for that. So all these things work. You gotta, you use what you can, right, in these situations. Now, in the future, maybe momelotinib will be approved for that. And so these are the things that work. And honestly, your patients will get all of them. My patients with anemia end up getting all of this because whatever works at any time, sometimes they respond and lose response. You move on to the next thing. So you do your best in these situations. Yeah.
Thank you, sir. Dr. Akhtar Shagak wants to know that any indication for splenectomy in the era of novel therapies for myelofibrosis?
Extremely rare. Almost, I've never recommended a splenectomy. Never in 10 years. Sometimes they do it right during the conditioning regimen for transplant. Like you do it and they go for transplant. But to do it for a patient and not doing a transplant after is probably going to kill them faster than help them. The problem with taking out the spleen is that, yeah, big spleens are problems, but no spleen is worse because the minute you take out the spleen, all this extramedullary hematopoiesis will move to the liver. Those patients have progressive, very fast liver failure and respiratory failure. So you're just delaying the problem. You're shifting the problem. You're not saving your patients. Again, a bad spleen is better than no spleen. I don't think it. Now, if somebody going for a transplant today and the spleen is huge and the transplanter can't do anything about it without taking out a spleen, I would not say no to that. And that'll be in that context only. But to take out the spleen and leave the cancer in the patient, that is just going to be worse than doing nothing. Yeah.
What about the splenic irradiation and splenic artery embolization?
Same thing. In your desperate palliative settings, again, it's actually known that splenic radiation only works for 6 months. And whatever benefit you get from radiation will completely go away in 6 months. And embolization of the spleen has not been studied. And the whole teaching in spleen embolization is that you don't do a spleen embolization unless you're willing to do a splenectomy, because it could always lead to rupture or perforation or necrosis or other complications. So if you're not willing to do a splenectomy, you should not do embolization.
No, sir. Another question. Yeah, that's all. Oh, fine. We have finished all the questions from the audience even.
Oh, excellent. Thank you. Well, that was very interactive. Thank you guys very much. I enjoyed this a lot. Thank you.
If anybody from the discussions wants to ask any question to Dr. Yaqub, please feel free to ask, because I've finished all the questions from the audience. Let me have a check once again. Absolutely. Sir, is it true that we don't offer even partial splenectomy also for myelofibrosis?
So what's partial splenectomy?
Half spleen gone, not the full spleen. Don't take out the full spleen. Let the spleen be there. Some spleen, part of the spleen be there inside.
I don't know how you can do that though, because when you take out the spleen, you have to clamp the artery and the vein and take it out as one piece. Now, we've had patients who had splenectomies in the old days. They still grew another spleen, honestly. Second spleen. They grew another spleen. But no, there's no way to cut through the spleen surgically. You have to clamp it and take it out in one piece. So an embolization again is not an option again. So outside of in the setting of a transplant regimen, drugs work very well actually. JAK inhibitors are very effective. There might have been an era where splenectomy was something people had to do. We really rarely have to do that anymore with the JAK inhibitors.
Thank you, sir. So if no other questions from the discussants, and I've finished all the questions from the audience, well, thank you so much, sir, for being with us. And it was
Thank you so much. I enjoy this a lot. I appreciate you guys all. Thank you for the invitation.
It was fantastic, awesome, and what a wonderful discussion. Thank
you
you
so
all
much.
the discussants for being with us. Thank you all the audience for taking part in the discussion. Thank you, sir, for being your fabulous, awesome, fantastic lecture. And what a wonderful discussion. Thank you for
Thank
being
you
with
all.
us.
You're welcome. You're welcome.
Thanks a lot.
Bye-bye.